special edition of AMR Masterclass 3.0. This session is unique and exclusive in more than one way. It is both a privilege and honor to be associated with American Society for Microbiology, which is one of the largest life sciences and microbiology community globally. This edition is special also because this is planned exclusively and only because of the feedback interest we got all of you on the AST reporting sessions that we've done earlier. This session is a curtain raiser to the 5-part certificate course that we will be doing with Dr. Sumit Rai and American Society of Microbiology. This course will have all the practical aspects of AST reporting covered. Yes, and post attending the 10 hours of this training module, you will be certified by the American Society for Microbiology. With this outline, let me take this privilege of introducing to you the two experts in our curtain raiser session. I would like to welcome Dr. Reba Kanungo, ma'am. Ma'am is Dean Research and Head of Clinical Microbiology at Pondicherry Institute of Medical Sciences. Her illustrious career spans with credentials such as Laboratory Program Advisor for Center for Disease Control and Prevention at Atlanta, Global AIDS Program provided technical assistance to NACO and SACS through US government partnership with Government of India and MOHFW. She's been Professor of Microbiology at JIPMER Pondicherry. She was also deputed to Nepal as Professor and Head of the Department of Microbiology to be Koirala Institute of Medical Sciences to Government of India and Nepal. She was also trained in CDC Atlanta on strengthening laboratory management. Ma'am joins us as former ambassador of ASM for India. And yes, we also have with us Dr. Sumit Rai, who's Professor and HOD, Department of Clinical Microbiology, AIMS Vijayawada. He's also been former additional professor, Department of Clinical Microbiology and Infectious Diseases, Postgraduate Institute of Child Health, Noida. His illustrious experience in clinical microbiology with 42 research publications, 1 book chapter. He's MD Gold medalist and PDCC is also done PDCC in infectious diseases. He's got a lot of IMM national awards for best papers in bacteriology, IMM Delhi chapter awards for best papers in AMR and AST. I can give, endless introduction to Dr. Sumit Rai, but I think his in-depth knowledge in the subject and his simplification in the way he illustrates this complex topic to the viewers has what made this topic and Sir himself popular among the viewers. So it is our honor and privilege. I welcome Dr. Reba and Dr. Sumit to this platform. Thank you so much, sir and ma'am, for joining us today. With this, I would like to hand it over to Reba ma'am to take us through current status of antimicrobial resistance and need to look beyond the laboratory report. So give me a second. I will share the slides. Is my screen visible? Hello?
Yeah, go ahead, Dr.
My screen is visible, right? Reba ma'am?
Yeah.
Yeah, actually, I have...
Reba ma'am?
Yeah, shall I start?
Yes, ma'am. You can start, ma'am.
But this disturbance
there is some echo which is coming from your end, ma'am.
But I've switched off my mobile. I've in fact done power off.
There is echo. Mm, maybe you can start speaking, ma'am. Let's see if it continues.
Okay. Um, so at the outset, I must thank BD and the organizers for giving me this opportunity to introduce a very important topic that we're going to discuss, which Dr. Sumit, with the powerhouse of knowledge, is going to have a series of classes. And this is actually what is the call of the day. So today, microbial resistance and need to look beyond the laboratory report. A disclaimer, this presentation does not endorse any product, company, or organization or academic body, and I have referred to publications, articles, and statements in the public domain. So coming to the global scenario, we all know the bacterial infections unsuccessfully treated due to AMR can claim up to 70,000 lives, 70 lakh lives per year worldwide. Antimicrobial resistance beyond the COVID-19 pandemic, we have seen how the COVID pandemic caused a sudden spurge in the use of antimicrobials, be it doxycycline, be it azithromycin. Left, right, and center, these antibiotics were used. And it is projected to be associated with deaths of 10 million people per year by 2050. And the cost of US dollars 100 trillion to the global economy through loss of productivity. Now, the current concerns are AMR will worsen post-COVID-19 due to the overuse of antibiotics in humans. This has been established by data from 5 countries, which suggest that 6.9% of COVID-19 diagnoses are associated with bacterial infections, but the US multicentric study reported that 72% of COVID-19 patients received antibiotics even when not clinically indicated. So you can imagine, although only 6.9% had bacterial infections, 72% of the COVID-19 patients had to have antibiotics. So this was a big challenge, and overuse and misuse of antibiotics in the COVID era. So what are the challenges that have been brought out by this? The resources directed away from the AMR surveillance. Naturally, we have all seen how COVID has taken the healthcare system by surprise, and the whole healthcare system went topsy-turvy trying to manage the COVID pandemic. The increase in preemptive antibiotic prescribing to prevent secondary bacterial infections took a stand. Continuing antibiotic overuse in agribusiness is the other problem. Delays in AMR legislations, antimicrobial drug shortages, almost empty pharmaceutical pipeline, and low public awareness of AMR. So this has brought us a concern. And what is the concern? The concern is crisis fatigue. When there is a crisis, the population goes into fatigue. And this is what we are now expecting or seeing in the AMR scenario. Just to give you one small example, the sample-wise susceptibility percentage of Acinetobacter baumannii. This is an AMR paper which has been published in the Indian ICMR 2020 guidelines, and they have seen that only Acinetobacter baumannii. I've just picked out one organism which is now has become almost a gunpowder in any infection in any hospital. And as you can see, the resistance to the blood isolates, the susceptibility is only 15 to 16%, which means that another 75% of the Acinetobacter have already become resistant. So where does that leave us? That leaves us only with colistin. And colistin is around 93% susceptible. So the only antibiotic which can save is colistin. And we know the drawback and the danger of use of colistin. So What are the opportunities, therefore, that are there for us? The hospital AMR surveillance, which is very crucial, prioritizing antimicrobial stewardship programs, develop rapid diagnostics, embrace One Health approach, ban medically important antibiotics in agribusiness, incentivize new antibiotics and other anti-infectives, and most importantly, leverage infection control principles from the COVID-19 experience. We all have undergone the infection prevention strictly adhered to in the COVID-19. So that is what we need to leverage now and implement it in the hospital completely. Now, what is the strategy that has been adopted by the government of India? In January 2020, the Indian government introduced draft legislation to place limits on antibiotic residues released into the environment at pharmaceutical manufacturing sites. This has been implemented strictly. The overarching goal of National Action Plan on Antimicrobial Resistance to effectively combat antimicrobial resistance in India and to contribute towards the global efforts to tackle this public health concern. So, in this connection, the Government of India, in collaboration with WHO, has come out with a Samiksha, that is a discussion on the antimicrobial resistance in compilation of publications resources on AMR along with brief summary. And this aims to review and share information according to strategic priorities of India's National Action Plan on AMR by creating awareness and understanding. Laboratories and surveillance, taking into its purview the laboratories and surveillance tools, implementing infection control and prevention practices, optimizing use of antimicrobials, research and innovations, and collaborations to facilitate containment of AMR in India. In this context also, the Government of India has brought out a treatment guideline for antimicrobial use in common syndromes, which should be very useful, and especially for microbiologists. It would be important for us to have a look at this because that will help us in our reporting systems. When we look at the samples which are coming in from the clinical sites, we can use this strategy to test for the specific antibiotics. Now, after this, we've been discussing, we've seen the total global scenario, the country scenario, the plans, the programs, and the rules and regulations. But what about the clinical microbiologist? What is our role as clinical biologist in rationalizing antibiotic treatment, in containing antimicrobial resistance, and are we still reporting the SIR, sensitive intermediate resistance, and what impact does this have on the clinicians, treating physicians? To this end, there have been several articles which have been published, Roles and Challenges of Clinical Microbiology Laboratories in Antimicrobial Stewardship in Resource-Limited Countries. This is a very good article, and it will help us to look at the perspective of the laboratory in developing countries. Then antibiotic stewardship, the role medical laboratories play, guide to infection control, the microbiology laboratory role in infection control, and finally antimicrobial stewardship, how the microbiology laboratory can right the sinking ship. So, the microbiology laboratory is a surveillance and early warning system. All of us know that as microbiologists. So, I think there are some of the participants, maybe they can mute their slides. Neha, if you can address them.
Ma'am, actually, the participants are at the other end of the webcast, so they are automatically on mute.
But okay, let's see. It's only when I talk that it comes. I don't know. I switched off my mobile. Sorry about this painful presentation.
Ma'am, no worries. We are still able to understand, and the slides are, there, so they are able to help us. So I am at least able to understand, comprehend everything, ma'am.
Okay, I'm extremely sorry for this horrible presentation. the microbiology laboratory is a surveillance and early warning system. All of us who have worked in clinical microbiology labs do know that anytime the antibiotic, when we're taking the reading and we come across multi-drug resistant, we are the first people to realize that there is a rise in, or there is a isolation of a multi-drug resistant organisms, be it carbapenem resistant or ESBL producer or MRSA. So we as microbiologists are the first people to realize this. The first task, therefore, of the microbiology laboratory is accurately, consistently, and rapidly identify the responsible agents and identify their antimicrobial resistance pattern. After this, Dr. Sumit is going to take us through the various ways by which this can be done in a routine lab. Laboratory-based surveillance is efficient but incomplete because of the lack of clinical data. So as clinical microbiologists, what should be our responsibility? We should encourage and we should educate the clinicians and the prescribers in providing the adequate clinical data so that the reporting becomes important and worthwhile. Unusual events or trends are usually picked up by us as clusters or multi-drug resistant organisms emerge and are usually first detected by the laboratory. And detection of antibiotic resistance phenotypes, these are again very important for us to pick up these organisms in the lab. And it is not enough that we just say, oh, today I have reported one carbapenem resistant so and so. Have we reported it to the clinician? Have we seen that it has impacted the treatment modalities? The microbiology laboratory, therefore, is also a sentinel system that requires prior notification, proper notification. Informatics are playing an increased role in the improvement of these processes in terms of workflow, timeliness, and cost. Use of WhoNet, smartphones to convey reports, and the treating physician should be alerted to selected pathogens like MRSA, VRE, ESBL producing Enterobacteriaceae, carbapenem resistance, Enterobacteriaceae, and Acinetobacter. And the other important thing that microbiologists can play an important role is periodic reporting, analyzing your MDR data and circulating it to your clinical colleagues so that they are aware what is the status of the antimicrobial resistance in their setup. So these are some of the very important, crucial roles that microbiologists have to play in order to bring about, control the AMR that is rising like wildfire. So the aim is to optimize antibiotic prescribing to improve patient outcomes with minimal cost, potential toxicity, prevent emergence of resistance, and reduce overall healthcare cost. Quality of pre-analytical phase, interpretation of culture and antimicrobial susceptibility results, ready-to-use microbiological strategies to deal with each specific infection. I think Dr. Sumit is going to throw more light on this. And as I have already mentioned, early reporting system, especially going into the laboratory information systems, LMIS or WhoNet, and sending out reports immediately to the end users. First and second line choices based on bacteria, antibiotic groups considering sites of infection, and particular patient conditions as well. This is again very, very crucial. We should not be just sitting in the lab like technical staff and reporting blindly. We should look at the patient. We should know that this sample has come from a particular patient. What is the background? What are the infections? And how is the antibiotic going to act on that? So these are some of the things that as clinical microbiologists, we must take into account. Then coming to the methods that can be used. All of us mostly use the disk diffusion method, which is the adept at most of the settings. And antibiotic bacteria interactions can be evaluated only with a quantitative method like MICs. And so based on this, what are the points to take home? Inferring susceptibilities to other agents from one result. This is something that Dr. Sumit is going to stress on. Sure. Looking at what are the possibilities, what does the antibiotic susceptibility plate tell us beyond just looking at the sensitive, intermediate, and resistant? Does it give us any other information beyond that? To promote judicious use of antibiotics, the most recommended approach for antibiotic susceptibility results reporting is the selective or cascade. Now, just because we are putting a whole panel of 10 antibiotics, it's not necessary that we should report all 10. We should be judicious in reporting what is essential for the patient, looking at the background, and withhold some of the higher end antibiotics for subsequent use. Enterobacteriaceae, mostly Klebsiella species and E. coli, if resistant to ticar. Just an example I'm giving you. Ticarcillin, but susceptible to piperacillin. Then what should we do? Should we report ticarcillin and, should we report piperacillin? Then we have to edit piperacillin to resistant. And these rules can be added to the WHONet rule database. So that is the importance of having a software to help us to choose to report the antibiotics. Susceptibility results of imipenem are not reported for cefotaxime, ceftriaxone, ceftazidime susceptible to E. coli. Now see here, this is very, very crucial. You know, as a routine, we are putting imipenem, ceftriaxone, ceftazidime, cefotaxime. And then what do we see when the report goes out to the clinicians? All of these are reported. This is not what it should be. We should be judicious and withhold some of these antibiotics. So this is just a small little opening to Dr. Sumit's series of lectures. And so the monitoring antimicrobial susceptibility of bacteria generates a database that is useful for elaboration of hospital formulary, hospital antibiotic treatment guidelines, example, first choice alternative treatment organized by sites of infection. So we must have a target and keep the antibiotics working. So to conclude, contribution of microbiology laboratory is to guide the antimicrobial choice, to support successful patient outcome, minimize adverse impacts in terms of antimicrobial selective pressure and costs. So with these two important statements, I shall conclude my presentation. And thank you once more for the patient hearing. And I'm extremely, extremely sorry for this poor presentation. One, of course, is my sore throat. I'm not well, actually. And secondly, my laptop is giving some problem with this extra noise. I'm really very sorry. I hope I'll be excused. Thank you very much.
Thank you so much, Reba ma'am, and I no need to apologize. I think with this digital thing, we are used to a bit of technology disruption here and there. But these words of wisdom from, even this echo could not, minimize the essence of the words of wisdom that you have shared with us. So absolutely wonderful and very insightful presentation. And I'm sure, the audience would have equally enjoyed it and learned from it. Thank you so much, ma'am. With this, I would like to invite Dr. Sumit to share his, brief introduction to the session that we will be commencing. Yeah, over to you, Dr. Sumit.
Good evening to all of you, and good morning to Reba ma'am. It's a very old, you can say that audio-visual issues are, whenever they happen, that's the pathognomonic for a successful CME. So they should happen. So they are an indication of a successful CME, actually. So it's okay. I mean, your presence and whatever that the things that you said, they are extremely, extremely important for today's scenario, and you have to brief people about what is the major issues regarding AMR, this being a global pandemic, now being recognized by WHO, and now even the President Biden government has also recognized and released a lot of funds for AMR issues. So thanks to BD, and thanks a lot to Reba ma'am for promoting us and laying the foundation for this series of webinars from under the umbrella of ASM and BD. So in this course focus, the primary focus will be on developing the site-specific bug panels, the selective reporting protocols, clinical footnotes, developing cumulative antibiograms, and therapeutic indices. So before I proceed further, Dr. Neha, I hope there's no background from my end, no background noise, everything's okay?
Yes, sir. We are able to hear you clearly.
Great. Thank you so much. So I'll just begin with this disclaimer, just the way ma'am had also started, that there are no conflicts of interest involved, and this is purely an academic exercise, purely for academic reasons, and we are not here to promote any specific brands. What I want to say again is that I'm a keen observer of the protocols and processes of antimicrobial susceptibility testing. I do not claim, and I even refute if anybody calls me an expert. I'm not an expert. I don't have all the answers to your questions, but I will never have all the questions or all the answers. But I will definitely learn to search and learn as much as I can. What I have time and again said that we are just like bacteria, and we must remain in the log phase of our learning, because if we don't keep on finding new food for thought to learn something new, then ultimately we go in a phase of decline, and we die off. And in this presentation, I'm going to display some reports from labs which highlight the current practices of antimicrobial susceptibility testing. And being an NABL assessor also, I have witnessed multiple labs, probably I can say safely around more than 100 labs, with the kind of AST reporting which is happening. Some are very good, but some are, well, I would say, no, you can't even mention that. So, as ma'am has already said that you're going to have at least 10 million deaths per year in the year 2050, thanks to AMR. And if AMR is not contained, and it's going to cost a huge amount of money, and a major economic burden is going to be there if this happens. And now what I'll be talking about is the factors which are responsible for the existing AST reporting practices. Why this has happened, at least my experience I'll share. What are the existing reporting practices? What are the actual report screenshots? What is wrong with what are AST reports as of today? What should be the ideal attributes of an AST report, and how to enforce good laboratory practices into the AST reports? Now, this is just an Indian scenario, what I'll be discussing primarily, because now recently I've been trying to search for an article that I witnessed, few days back, like a few years back. This article was published in Journal of Clinical Microbiology, and this was basically the external quality assurance EQUAS report that was published by the PT provider, that is a proficiency testing provider. He had that lab had actually sent a specimen to all the participating labs, and it was basically the history was like, the urine specimen of a 20-week pregnant female is sent for culture, which isolated Streptococcus agalacti in significant counts, and the isolate is being sent to you. Please present the findings. So basically, that was the crux of the question that was sent by the PT provider to the participating lab, like a typical EQUAS program that we also are participating. Now that lab, now this is probably, I think this was in the US, and around 15 labs had participated in this, only out of which, around 9 or 10 labs, they gave the full report that this is susceptible to so-and-so, 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 so-and-so. They gave a list of around, 10 odd antibiotics. Then there was another lab which did selective reporting. They said that, okay, we'll just report only 5 antibiotics. Then there was 3 labs, I think, only 3 or 2 labs, which specifically said that Streptococcus agalacti in the urine, I think, yeah, Streptococcus agalacti in the urine is basically representing the colonization of group B Streptococcus in the female genitalial tract. And since group B Streptococcus is pan-susceptible to penicillin group of drugs, so no ASTs to be reported. So that was the kind of report that they sent. So that is the impact of what the microbiologist must know, what to report and what not to report. So that was one very interesting article. Unfortunately, I remember the crux of the article, but I am not able to still find that paper. I'll try to trace it if possible and share it. So first of all, I'll just discuss the factors which are responsible for the existing, I would say, havoc that is primarily caused by the AST reporting practices which are doing. So since we all know that our MD program has been majorly flawed, because we as MD students and even as senior residents are not allowed to ask questions to our seniors. For example, when I was doing my MD and I asked somebody that, that time it was NCC-less, and I asked that NCC-less advocates the use of Muller-Hinton agar, and that time the UCAST used to use the isosensitive test agar. So why are we using nutrient agar? So a senior person, he said that don't argue with me. We are using nutrient agar because it's 1/3 or 1/4 the rate of Muller-Hinton agar, and so you don't tell us what to do. You don't know anything. So that is one thing that we are not asked to question our seniors as to why certain practices happening. So we take it also casually. Okay, if doesn't matter, how does it matter? Is nutrient agar or MHA? Then there were reports again sent by many people who did not differentiate between what are therapeutic discs and what are diagnostic discs. Actual final report of ceftaroline clav was being sent on the patient's report. Ceftriaxone clav or cefotaxime clav was being sent on the patient's report. These are diagnostic discs. These are not therapeutic discs. So again, that differentiation, unfortunately, many people are not doing and sending the wrong reports. Then wrong practices. Now, wrong practices like not using swabs for AST. Now, how is it possible? How can that be even possible? Normally, we make a 0.5 McFarland turbidity standard. We dip the swab inside. We take out the excessive inoculum, and then we swab our MHA plates. So one place I saw a practice where they used to, the tube is there. They used to just tilt the tube so that the liquid goes into the cotton bung, and they used to take out the cotton, and from that wet area, they used to swab the plates. So there is no idea about the amount of inoculum that is going on the plates. So that is also wrong practice. That is actually been done. I'm not cooking these things up. I've actually seen these things happen. So these are wrong practices. So people don't have a idea that how should be the amount of the inoculum on the plate, because AST is something that it's a very, very, we are trying to do something very on a controlled pattern and trying to predict what's going to happen in a very unpredictable platform like the human body. Then there used to be a concept of the antibiotic lab. Now there's a blood seed, there's a urine seed, there's a pus seed, there's a respiratory sample seed. So what they used to do, they used to pick up the isolates, put it in the peptone or whatever, saline, whatever, and they used to send it to an antibiotic lab. Now the antibiotic lab is just receiving a LF, lactose fermenter, non-lactose fermenter. So that's it. So there is no coordination between the antibiotic lab and the place where actually the forms are present, the patient forms are present. So there is no correlation. In most of the places, in good places, the AST is put on the same site where the primary specimen is being processed, so that you have at least the history of the patient, little bit of history, whatever is there, male, female, adult, all those things, at least basic things are present. So that concept of a separate antibiotic lab, I fail to understand, because that totally delinks whatever patient history you have with what actual AST that you're putting up. Now, there were actually people who had very high egos also. They said that I don't need to sit in seminars. So if you are getting trained by such people, so they are not likely to impart the entire knowledge that they know if they've got so much of egos and ethos are there. Then we used to have pathological visitors in the bacteriology lab. Now, what are pathological visitors? Now, somebody, microbiology and pathology departments are usually adjacent to each other, or at least one or two floors up and down. So the senior resident from pathology who was about to finish his or her senior residency used to visit the microbiology lab for 2 or 3 days just to find out that how do you put up the AST. Okay, if it is LF mucoid, it is Klebsiella, then this AST. If it is LF flat, it is this, then you put up this AST. So that is the basic idea. They felt that microbiology is just, AST is nothing. It's very simple. And they just know 3 bugs, which is your E. coli, Klebsiella, Pseudomonas, and maybe Staph aureus. So we used to have a lot of pathological visitors in the bacteriology lab, and these pathologists, they are actually doing the reporting in the pathology labs outside, and they are sending the reports, and I'll just showcase those reports also. Again, there was no concept of quality control, quality assurance, because it was all mixed things. There were some areas where they were doing modified Stokes method on MHA. So again, there used to be NCTC strains. There weren't any ATCC strains. There were no EQUAS participations also. So there was no concept of accreditation. There was no concept of lab quality control, quality assurance. Nothing like that. So in the end, people who are passing out their MDs from such institutes don't have any clue about these kind of essential processes and protocol which will improve your AST reporting. Then what comes is the the conflict of interest from the pharmaceutical companies. Now somebody, the person the faculty who's in charge of the AST will suddenly call you up and, okay, these are the cephalosporin sulbactam discs. I wanted to put these discs in all the gram negatives. Okay, then what should be the zone diameter? Whatever the Magnus people have said, it's 18 millimeter. Now, Magnus is cephalosporin sulbactam. The zone size of cephalosporin is 21. How can cephalosporin sulbactam can be 18, less than the primary? So it is very, company driven. Some of the antibiotics are company driven, like cefepime tazobactam. That was being pushed by a company for a long time. But then there were people who never took those antibiotics because those BL-BLA combinations don't follow the same PK/PD pattern once they go inside the human body. So there are some drug and BL-BLA combinations which are not useful, not to be used. So what we are actually making them are glorified technicians, lack the common sense, focus only on bench work and T clubs, no clinical work. Again, I'll give you an example. I was a first year PG, posted on the blood seat, and I noticed that a particular pattern of Klebsiella was coming from neonatal ICU. First isolate, second, third, fourth isolate. So it was common sense just to have this inquisitiveness to go to the NICU and find out what is happening. So first I went over there, I spoke to the faculty in charge of neonatal ICU, and he asked me, okay, who are you? I said, I'm first year PG from microbiology. So he said that in my career, I'm seeing first person from microbiology come to the clinics. So that is the way that we were trained to become glorified technicians rather than MD, clinical microbiologists. So these are some of the problems which I have faced during my training, and how we and what is the impact, and what happens once these kind of things come into practice, like these pathological pathological visitors. Like for example, this is the report from XYZ pathology lab from North India. So I have tried to hide all these things, but still, if you see, this is a urine specimen that they have isolated E. coli. Now a pathologist knows only two bugs, E. coli or Klebsiella. It's either E. coli, it's Klebsiella, it's never the third thing. Okay. So even the counts, it is a range. The count is a range, 10 to the power 3 to 10 to the power 5. It's not 3, it's not 4, it's not 5. There is a range that they've given over here. And just look at the kind of antibiotics that they've reported over here. Like in E. coli, they've reported, in the urine, azithromycin and tetracycline, and wrong drug specimen combination. In urine, they're reporting macrolides and chloramphenicol, and tetracyclines are not classically urinary antibiotics. Prulifloxacin. What is meropenem sulbactam? What is amoxicillbactam? So all fake drugs, all useless drugs, and are reported by a consultant pathologist. And even if you try to interpret what is the interpretive reading, what could be the phenotype, you will go berserk. It is cefotaxime and aztreonam susceptible, but it is resistant to piperacillin, tazobactam, ceftriaxone, doripenem, and colistin. Colistin resistant. So okay, so they don't even know whether it's E. coli or it's Proteus or Morganella providentia. So this is the kind of reporting that they do. Moxifloxacin susceptible, leofloxacin susceptible, lomifloxacin susceptible, but norflox resistant. So this kind of pluses. Is it susceptible, moderately susceptible, highly susceptible? So once I asked one of the technicians in these labs, because most of the pathologists, they are not looking at things. In fact, they don't even know what to look at. So the technician says, sir, if it is around 20-25 millimeter for any antibiotic, we give it as 1+. It is 25 to 30, we give it 2+. If it is more than 30, we give 3+. So basically, whatever fluoroquinolones give a huge zone size. So all fluoroquinolones come as 3+. So that is probably their rationale that they're giving. So they're totally useless. Now this is something that is actually criminal. This presentation, this slide. Now this particular lab is so-called NABL accredited, and they are also using the logo of International Accreditation Forum, IAF. They are using all these logos on their letterhead, and they claim to be a NABL accredited laboratory. And the reports are being signed by a pathologist over here. 2 pathologists are signing the reports, and they have reported Pseudomonas in urine, which is they were reporting amoxiclav susceptible, chloramphenicol susceptible, nitrofurantoin susceptible. So these drugs are not put because of intrinsic resistance. Nobody has got any idea what intrinsic resistance is. Nobody looks at CLSI M100. Nobody looks at the appendix B of CLSI M100. So they reported all nonsense things. Cotrimoxazole, 3rd generation cephalosporins, which are not ceftazidime, cefotaxime, ceftriaxone. 1st, 2nd generation cephalosporins they've reported. Tetracycline and what else? Teicoplanin. A gram-positive antibiotic they've reported in Pseudomonas aeruginosa. So this is the level of crap. I would say this is the level of crap that is happening in such kind of labs. In fact, a complaint has already been sent to NABL that this is the particular lab which is, using the NABL logo, and this is the kind of, because AST report, the way histopathology reports cannot be signed or cannot be validated by MD microbiologist. Similarly, the AST reports cannot be validated by a MD pathologist. It only can be done by MD microbiologist. Same thing. Fortunately, they got an E. coli in this report. So this E. coli is susceptible to, they have reported all these antibiotics. So they are all common. There's the same list of antibiotics here. It's just that they have reported chloramphenicol wrong, tetracycline and teicoplanin again, because same set of antimicrobials, just because this is Pseudomonas, so these are all wrong. And because it's E. coli, though, it's just a fluke that it is okay. Now, say same lab, same authorized signatories, both are pathologists. So this is the condition of the labs where pathologists are doing the reporting of AST. Now, these 2 reports are from labs, which unfortunately I know the authorized signatory, and therefore I have concealed the reports and the names also. And despite the fact that they both are microbiologists, they have reported, like in blood, in E. coli, they have reported phosphomycin in blood. And they've reported tigecycline in blood, which is not to be done. Tigecycline does not maintain any serum concentration. The moment you give, it immediately shoots into the tissues. So there is absolutely no concentration, no levels of tigecycline in the blood. So that is one of the reasons why FDA does not, they don't very strongly advocate any kind of levels. Again, this is also, you can see, this is signed by an MD DNB microbiologist. Consultant microbiologist is also, the list of antibiotics is right. There is nothing majorly flawed with this, but then 2+, 3+, 2+, 3+, that's a classical pattern that is seen in North India, unfortunately. And for some reason, the signatory authority has to, under probably some pressure or something, they have to comply. So these are the wrong practices. Another report, I'm again maintaining the lab confidentiality. I don't think that the names are evident anywhere. Again, there are a lot of pluses over here, 3 pluses, 2 pluses. And what is ceftazidime clavulanic acid is being reported here, like I said. Cefepime tazobactam is being reported. There are no breakpoints. Pazufloxacin, I don't know what is this antibiotic. Prulifloxacin. So all are again reported by a pathologist over here. In this report also, there is a pus specimen. Pus specimen, that is, they are reporting amoxiclav for Staph aureus. At the same time, they're saying that this is, they've not even mentioned this is MSSA, because they claim that this cefotaxime is susceptible, but they're reporting 3rd generation cephalosporins like, ceftriaxone, cefotaxime, cefepime also they're reporting, and BL-BLI combinations where there are no breakpoint zones available in CLSI. It clearly says if it is MSSA or MRSA, and thankfully for beta-lactamase, they've put up at least penicillin they've put up. And that too, I'm sure that is by fluke only, not by choice. This is another report showing, a lot of pluses, again from North India only, all these reports reporting tetracyclines and chloramphenicol in urine. And again, 4+ and 3+ and 2+, all total nonsense. This report, unfortunately, again, is from a NABL accredited laboratory, and just look at the kind of things that they've done. This is a urine specimen that they've isolated. They say that they've got a lot of pus cells. Now, what is the matter over here is that they often correlate with the microscopy findings from the pathology lab. Okay, this is a specimen that is reached in microbiology. What is the microscopy report from pathology? So pathology do the microscopy on a centrifuge urine sample. So they will see epithelial cells, lot of epithelial cells, lot of pus cells will be there. They'll see RBCs also. And the count is only 10 power 3. So ideally you should have either, sent it as a non-significant growth, but then they're testing for amikacin in enterococcus. They're testing for amikacin, amoxiclav, ampicillin, cefazolin, first generation, second generation cephalosporins are being reported, cotrimoxazole, so all total nonsense. And that is, again, like I said, this is an NABL accredited laboratory, and this reporting has been done by MD microbiologist. So this is the condition of MD microbiologist, what to accept from MD pathologists and the PhDs. No offense, but that's a fact. So again, urine from a sterile container has been sent. The Enterococcus fecalis has been isolated. Again, amoxiclav, same lab, the one which I mentioned previously. Macrolides being reported. Glycycyclines, tirycyclines being reported in urine. Amoxiclav reported in Enterococcus fecalis. And this is, this is a gem, Salmonella typhi, being reported in blood, and they are reporting nitrofurantoin in blood, and tirycycline, of course, and amikacin, because they aminoglycosides and tirycycline, they may be susceptible in vitro, but they do not respond in vivo. This is again classically mentioned in CLSI, but then as usual, nobody reads M100 document. Nobody reads. Over here, I want to trash one of my own reports also. This is one of my own reports, which I have sent, I think this was in 2021, February. And this is reports I have always generated from the WHONet with some clinical footnotes. And I failed to do selective reporting in this case. I did not do selective reporting. I missed out on the CR number, or the LIS number I was missing, and did not mention what method, because this is automated plus manual, because we don't have nalidixic acid or cefoxidin in the gram-negative panels. So I've reported here. So again, I have also done a lot of mistakes, and I've learned from my mistakes also. So slowly and slowly, we evolve. So what should be the ideal attributes of an AST report? So these are the basic attributes that, according to me, should be present on the AST report. Now, there might be more, or some people might argue that you don't need to give so much information, like patient demographics has to be there, of course. CR number, patient specimen, what is the specimen? Now, again, CLSI and ISO guidelines also specify that whatever that you are obtaining from the patient directly, that is a specimen. Once you divide it into multiple things for different investigations, that division becomes a sample. So you can have a EDTA vial having 5 ml of blood. Once you divide it into different parts, those become samples. So there's a difference between specimens and samples. Traceability, where did this specimen come from? Who was the patient? Was the OPD, IPD? What was the department? Diagnosis. Now, this is something that even fails with the HMIS, because even our system over here in AIMS has got an HMIS, but we are at times not able to trace the diagnosis. One reason, because the patient is coming from the OPD, it's not even written, because the forms are raised by the the nursing staff. Many times they don't know the diagnosis, and unfortunately the ICD-10 or the ICD-11 has not been incorporated in most of the HMIS softwares, on the basis of which the actual diagnosis can be traced, especially for the cumulative antibiograms and the antibiotic policies. Gram stain findings, wherever possible, wherever applicable, always has to be mentioned, must be mentioned on these reports. Specimen acceptability counts like Bartlett counts or Q scoring also has to be mentioned on the AST reports. Correct drug, bug, and specimen panels have to be chosen. So either like these examples which I just showcased, chloramphenicol in urine, clindamycin and cotrimoxazole, cephalosporins in enterococcus. So these things have to be really taken care of carefully. Organism, the actual name, the full name of organism, serotype if applicable, and the semi-quantitative count in case of urine, or it's got a heavy growth or a. So you must know that what was the clinician must know what was the inoculum, or what was the load of bacteria that you are dealing with when the primary specimen was sent to us. Of course, selective and cascade reporting is absolutely mandatory, and whenever possible, time to positivity, especially for blood cultures, also should be given ideally. wherever possible. So some places, and it's usually possible only when you have an automated blood culture system. Normally, only then it is possible. Now, this is not an ideal report, but again, I am saying that whatever best that I could do, this is again from my previous institute. This is the upper half of this report. Now, these are actually two reports. The upper half is normally generated by the WHONET. The lower half is generated as a special notes which are taken out, and the backside I'll just show you in the next slide. Again, this is a case of Salmonella typhi over here, and we have reported only 7 antimicrobials: azithromycin, pfloxacin, nalidixic acid, cotrimoxazole, chloramphenicol, ampicillin, and ciprofloxacin. And we have sent some comments whether it's ESBL or not, or negative, AMC negative, carbapenem negative, nalidixic acid resistant Salmonella typhi. And we have also mentioned that according to CDC guidelines of August 2020 on selective reporting, we are not reporting all class of drugs. So we are holding many class of drugs. So this is the kind of, and this report is also sending you exactly what was the date and time on which this report was generated. So that also shows the actual turnaround time for that particular test. So we have put up only the first line of drugs, which are ampicillin, chloramphenicol, chloramphenicol, cotrimoxazole have been put up. No third generation cephalosporins are reported, even though we did put up the Vitek, but they have not been sent on the final report. Only this filtered reporting or the selective reporting has been done. No high-end antimicrobials have been reported. And we always keep on a daily QC cycle of curryword distribution and not shifted to weekly QC. This is the backside of both these reports with the MIC-based quotient or therapeutic efficacy-based reporting, which I'll be discussing in the subsequent lectures later on. So this is and then we in the end we try to recommend that most effective drug is most likely to be ampicillin in this case. Try and avoid third generation cephalosporins. Unless the patient is very, very sick, you can always go in for ampicillin, which has got a higher MIC quotient as compared to ceftriaxone, which is normally only 1. So all the selective reporting is over done. We not reported amoxiclav, piptazo, ceftriaxone, cefopron, sulbactam, cefepime, ertapenem, epenem, meropenem. Amikacin, we specifically written intrinsic resistance in Salmonella typhi, gentamicin, intrinsic resistance in Salmonella typhi, and not reported, drugs like colistin. And nitrofurantoin also is written only for urine isolates. So this is the kind of reports that I have been generating for a long time. Now this is something very typical. And especially, in the private setup, most of the labs in the private setup, and especially the standalone labs, they are facing this major issue. Like, for example, this swab came to us from the neonatal ICU. This was an umbilical swab, and we saw that there were no pus cells in the gram stain. So first we put up the culture, and then there was a single swab. So we put up the culture, and then after the culture, we made the gram stain. We found that there were no pus cells. Occasional gram-negative Coccobacilli was seen, and which came out to be Klebsiella pneumoniae, and which was probably both ESBL positive as well as carbapenemase producer. It was resistant to all the carbapenems. So instead of shooting out a report of colistin susceptible and tidycycline and all that blah, 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 we just said no. Let us find out the history of the patient. So case discussed with the clinician. This was a pus swab that was sent from the umbilical stump with a previous history of hospitalization in the ICU in the private hospital. Gram stain shows no pus cells and occasional gram-negative bacilli identified respectively as Klebsiella pneumoniae. It is a part of the escape group of organisms and established hospital flora, and the patient has got no systemic signs or symptoms and is afebrile. There are some spelling mistakes here. Since swabs, they collect superficial or transient and resident flora, such isolates do not represent true pathogens. This wound does not need systemic antimicrobials and may be treated locally with debridement, antiseptics, and topical powders like neosporin, bacitracin, or sulfacetamide combinations. The wound may be kept dried by avoiding ointments and use local powders, because ointments and solutions, they normally promote the growth of gram-negatives, and powders will normally keep it dry, wound, and likely to heal sooner. When the wound is debrided, aspirate may be sent from the advancing edge of the lesion. If the wound is not responding, in that case, you send the aspirate. Even if it is 0.5 ml, you send the aspirate. Enrichment can be done, and then we can see whether it is a true pathogen or not. So despite isolating a CRE, we did not send the full AST report in this case. So it is not required for every pathogen that we get in the lab. Now, what goes behind making these standards? Like, for example, we heard about M100 standard, M2 standard, M7 standard, M39 standard. Now the M52 standard will come up for the commercial AC systems. Then we got M23 standard for the blood culture system. So these standards are present by CLSI. Similarly, this ISO, this International Organization for Standardization, ISO, so they put a lot of effort whenever they are making standards, and quality control standards are involved in making these things. And those who have heard about ISO 15189, it is an international standard of ISO that is specifically meant for laboratory quality management system for the technical competencies for the medical testing labs. And this standard is incorporated in India through the localized version from India, like who would be the authorized signatory. So that is through the NABL 112. So now this standard is made by the technical committee 212. ISO has got a technical committee 212 that makes the standard of ISO 15189. Now, since ISO 15189 is dealing with all the labs, pathology, biochemistry, microbiology, this standard has got, this particular technical committee has got 6 groups, out of which one group is specifically dedicated for microbiology and molecular diagnostics. So if you see anywhere else, you won't find anywhere pathology, you won't find biochemistry anywhere. So one working group is specifically dedicated for microbiology and for making the standards for things like your ISO 20776 standard. This is again made by the Technical Committee 212 Working Group 4, sorry. As you can see over here, ISO Technical Committee 212 is the one that makes this particular standard. And this is a very, very highly, you can say accurate standard that they've made, highly precise, highly accurate, highly tested standard for broth microdilution. And this forms a basis to form our breakpoint zones. So this is the primary standard, this is the source, the actual source of how the broth microdilution reference method is done. And just imagine the effort which is made. This standard costs 118 Swiss francs. That's somewhere around 10,000 rupees. And it has got only 19 pages. Only that. So this is the kind of money which is involved in buying these standards. So again, that is another major issue, finances. And which is why how to enforce this quality so that we don't get these kind of malicious reports that will only promote antimicrobial resistance is to start enforcing these things through National Medical Commission. That is our national, that is a statutory body which would enforce these kind of things. So enforcement is more important, because until, like we say, until it's not documented, it's not done. Similarly in India, until it's not enforced, it is not implemented. The reason why all the private sector laboratories, private sector hospitals are going NABL and NABH is because it is enforced upon them, because until and unless they don't undergo these, they don't get themselves accredited under hospital or laboratory standards, they will not be included in the health panels like CGHS or DGHS, ECHS and all those things. So similarly, on this basis, recently a very strong step was taken from National Medical Commission in 2022, this year in February. And a directive was sent to all the directors, irrespective whether they're Institute of National Interest, whether they are state medical colleges, whether they're private medical colleges. A directive was sent by the NMC to start implement the National Action Plan for AMR containment under the National Action Plan that was already released and till 2021. And then specific aims and objectives were given to everybody to start making antimicrobial stewardship based programs in their institute. So in our institute, I initiated the formation of the Antimicrobial Stewardship Committee. And this National Medical Commission, recently we had a meeting. I was on one of the panels with Dr. Sonal to develop the curriculum, resources and modules for training of PG students and senior residents. So this is the job that has been now different because of the One Health plan. Because AMR is not just a human issue, it is an animal issue, it is an agricultural issue, it's an environmental issue. If you see the report from CDEP, the 2017 report, you will find that there are antibiotics present everywhere, in the soil, in the rivers, in the environment, on trees, everywhere. The resistance genes are present. Now, to contain them, we have to have an integrated stewardship program, And on the same lines, we have made an antimicrobial stewardship committee at AIMS Mangalgiri. We have also initiated the process of starting the integrated antimicrobial stewardship lab, or the integrated stewardship lab, that will consist of all the different arms that will have the diagnostic stewardship, the antimicrobial stewardship, and the infection control stewardship. Because until you don't control the infection, it will keep on spreading. The AMR will spread from patient to patient. If you take an antihypertensive, it is just going to affect me. But if we take an antibiotic, it's going to affect the entire community. So that is why infection prevention control and diagnostic stewardship. So we are planning to open up a 24/7 lab. And as of today, I can again say that if we don't have a 24/7 lab in the hospital, and every microbiology lab has to be inside the hospital. Microbiology labs should not be, I repeat, microbiology labs have to be only placed inside the hospital settings and not in medical colleges. It's a crime to throw them out. These are clinical branches. So therefore, as one of the expert members, my initial suggestions, these slides are changing on their own. I don't know why. So the initial suggestions that I have given from my end is that most stringent and zero tolerance is that equate antimicrobials to antipsychotics. This I have been saying for the past 10 years. And I hope now at my age and my stage, I can take it to the government, and instead of this Schedule H drug, it has to be only and only through the prescription of a qualified medical practitioner, and only then the antimicrobial should be released. It should be a zero tolerance that antimicrobials have to be equated to antipsychotics. The way antipsychotic drugs cannot be given without the prescription by a psychiatrist, these reports also should be validated at least by a physician and by a microbiologist ideally. All these AST reports to be signed only by an MD microbiology and not MD pathologist, and that too who has done an AMSP course from a NMC accredited AMSP training center. Again, this has to be zero tolerance. You have to have the competencies to be able to sign these reports, to understand what are the complexities which are involved in the AST protocols. Financial assistance has to be given to the PG and SR, like these basic guidelines, CLSI guidelines. Many of the seminars, many of the things are paid. So the postgraduate students are not paid enough financial assistance to buy these courses for antimicrobial stewardship program courses, for online CMEs. So they should be given financial assistance. We must rename microbiology as clinical microbiology, and compulsory selective reporting has to be done, especially where all these standalone labs, it has to be made compulsory that only selective reporting will be done. And especially the standalone labs are under a lot of pressure to give 35 antibiotics. This lab is reporting 28 antibiotics, you should report 35 antibiotics. That's utter nonsense. And of course, to start a state AMR surveillance, already WHO is doing through in Kerala and in Maharashtra and in Delhi. We have also initiated in Andhra Pradesh now through WHO. And we have to separate the Hospital Infection Prevention Control Committee from the Antimicrobial Stewardship Committee. Both have got different domains. They've got different objectives. Both are very, very highly skilled and highly technical committees. And the nodal officer, infection prevention control, has to focus mostly on AMR surveillance, the hospital-acquired infections, the disinfection, the sterilization, the cleaning, the hand hygiene protocols, hand hygiene compliance, whereas the Antimicrobial Stewardship Committee will focus specifically on things like antimicrobial prescription auditing, the diagnostic stewardship, the antimicrobial stewardship, the antibiotic posology, surgical antimicrobial prophylaxis. So these are things which are, so this is the reason why I even convinced the director of my institute that, sir, the domain of both the committees is totally different. You need to keep them separate or everything will get mixed up and you won't be able to focus specifically on AMR and AMSP. Right. With that, I would just like to say that, it's time to, wipe the slate clean. And we have to realize that what apparently seems to be a very, very, simple thing is going to create a lot of havoc in the future. It is already causing a lot of havoc. I'll give you a live example. My uncle, he survived COVID. He survived COVID, but ultimately he passed off because of hospital-acquired pneumonia because of Acinetobacter. It was not COVID that killed him. It was Acinetobacter that killed him. So we have to be very, very strict on these regards when it comes to the AST reporting. And until and unless all these AST reporting attributes are not implemented and followed by the clinicians also, and what I'm trying to say that we need to do not just point prevalence surveillance for prescription auditing. We have to do a real-time real-time surveillance for all the AST reports which are being dispatched in the inpatients at least. So that is what we are planning to do in our setup, that all the AST reports which are planned, which are sent to the inpatient areas, the prescription auditing be done. With that, I end my presentation. Thank you so much for your time and patience.
Thank you so much, Dr. Sumit. This was a launch session, but I think you've actually highlighted a lot of salient points in this session itself. So now I will, just share my screen to flash the agenda which we have chalked out. So this with Sumit's input, this is the agenda that we've talked out for the next 5 sessions, which is actually the course commencement. So these are the topics. So the first session will be on developing site and bug specific panels. Next would be on selective reporting protocols. Then clinical footnotes in AST reports, then developing cumulative antibiograms, therapeutic index, and importance of MICs. These are the 5 sessions. In most likelihood, there will be 1 session per month, and therefore it will go on till August. Each session will be for 2 hours. We will be sharing, closer to the session, we will be sharing the invite with the date and time when these sessions will take place. And post completion of 10 hours of these sessions, so 2 hours into 5, you will be getting certified on this course. And yes, of course, ASM being one of the signatories of this certificate. Now, basis your interest, we really want this training session to be a closed and a small group. We will try to divide all of those who've expressed interest and joined today's launch webinars into groups, and take up the first group, say for this particular training module. So this is how we plan to roll it over the next 5 months. So wait for a confirmation email from us on your enrollment in these sessions. So thank you so much, Dr. Reba and Dr. Sumit, for joining us for this and giving us an overview on what can the audience expect in this training session. So stay tuned, and we will bring more on this to you. You can always access the VOD link, the video on demand link that we have.
Dr. Neha, you just got muted. I think some internet connection is there, some issue.
Hello, Dr. Neha, we can't hear you.
I think she's muted for some reason. I don't know why she's muted.
No, sir, I think there's some issue with the internet. Sir, so I think
just to give a small joke, I would say. Recently, last year, I attended a conference in AIMS Patna, and it was again on AMR and AMSP. And after the conference, I was going back to the airport with some of my colleagues, and they were saying that, oh, I've got, I had a bad stomach. Oh, I took Norflox TZ, now it's okay. So that's the irony, that's the irony of the situation, that, I don't remember, I've had so many colds and cough, and I've been COVID also. I've never ever taken any antimicrobial. In fact, once I was even exposed in the lab to Brucella also, but I didn't take a doxycycline coverage also. So I can say that I'm one of the actually the naive antibiotic, one of the naive persons when it comes to antibiotics.
Yeah, I would second that, Sumit.
I think Dr. Neha is disconnected, if I'm not mistaken. Darshan, are you online? Vinob, anybody
Yes, sir.
online?
Yes, sir. I am online, sir.
Should we leave the meeting now, or should we wait?
Yes, sir. Yes, sir. We can conclude this meeting, sir. So I'll
Right.
give the
Okay
concluding
then.
remark. So thank you,
Right.
Dr. Reba. Thank you, Dr. Sumit, for taking out your time for this event. So with this, I would like to, I would also like to thank the audiences for being patient through all the technical glitches that we had. And with this, I would like to conclude this webinar. So I'll be ending this webinar right now. Thank you.
Thank you so much. Thank you. Thank you, ma'am. Thank you so
ma'am.
much.
Thank you.
Thank you, ma'am. Thank you.
Thank you. Thank you so much.